Welcome to the Beyond Physio podcast, where we help you move, excel, and inspire others on your journey to your next level with knowledge and advice from experts and testimonials from our like-minded community. Welcome to the Beyond Physio podcast. I'm Dr. Jerry Yu, CEO and founder of Next Level Physio. Today, we have a very special friend, guest, Dr. Michelle Lupkin, who, among many things, has been a patient of ours, but she's also an expert in eating disorders. And we really want to dive into this topic because you'll see as the show goes on why. Welcome to our show, Michelle.
Thanks for having me.
Michelle, can you give us, our listeners, a little bit of background as far as your education and your specialty?
Sure. So I am someone who didn't take the direct path. I was an economics major a gazillion years ago, worked on Wall Street for a little bit, spent about 10 years easily being full-time mom to 4 daughters. And somewhere along the way decided, I want to figure out what I want to do when I grow up. I had always been somebody interested. I was pre-med at one point and dropped that, but interested in that mind-body connection. But I'm a scientist at heart. And when my oldest daughter was diagnosed with a chronic illness and we were working with a pain specialist in the hospital, that's when I started really learning about the science between mind and body. And then I was hooked. And so I had never taken a psych class in my life. I had to go do an almost full undergraduate major, a grown-up. I had to take the GREs as a grown-up. I think that was the worst part.
Terrible.
And I had to do well on them. And then I started graduate school at 38.
I love that story because for anyone out there who has maybe toyed around with the idea of changing professions, Dr. Lupkin is a great example of someone who, after 4 kids, not just like 1 or 2, 4 kids, still made it and has been very successful in her career. So I think that's a great inspiration for many people out there. So tell us, Michelle, as far as getting into psychology, you decided to go towards the eating disorder route.
No, actually, that was not anywhere on my radar at all. I went to Ferkauf, which is part of Einstein at Yeshiva, and I did a Ph.D. in clinical psychology with health emphasis. And so my training was as a health psychologist, right? Which is where you're really integrating psychological and physiological illness. And that was it. My research was in pediatric asthma, which, given a history with my daughter, was something near and dear to my heart. And then along the way, I ended up doing our practicums, we call them externships. I ended up in a couple of externs related to eating disorders. And what I didn't realize is I ended up surprisingly loving working with severe psychopathology, including adolescents with suicidality and self-harm. And in working with eating disorders, especially, I was on a unit, so it was a partial hospitalization program. I kept wanting to work with the kids that were the most disruptive on the unit, that all of the staff hated. And I had an amazing supervisor who helped me understand them and know how to treat it. And it just was this great blend of severe psychopathology and having to know the medical. And so it wasn't a straight path. And then once I put those two together, I've loved doing it, because when you're treating eating disorders, one of the things very similar to health psychology is you have to work in a multidisciplinary team. I'm not an MD, and I need to know the medical, right? I need to be aware of it. I need to know what questions to ask, but I need medical eyes and ears when I am working with anyone with an eating disorder. So it was not exactly a straight path. In my first year of graduate school, when they talked about certain diagnoses that are a lot of what I treat, I literally said, you have got to have your head examined. Who the hell wants to treat those patients? That's true story. Psychopathology 101 in grad school. And fast forward, I think learning how to treat it and really understanding it and having a more empathic view rather than a judgmental view of certain types of illnesses. It's like that fighting for the underdog. I'm a Mets fan too, so I got to fight for the underdog. So I didn't expect to end up in eating disorders. And even my first job after I was licensed wasn't eating disorders.
Oh.
Yeah.
That's interesting. So you took the circuitous path that led you to working in the specialty of eating disorders. And now you've really enjoyed it, and it's become sort of your thing for the last how many years now?
Private practice or just general?
In general, yeah.
So I've been treating patients with eating disorders off and on since I was doing my practicums in grad school, and then through my, not as much my internship, but in my postdoc, I did it as well. And so since I've been full-time, but then along the way, I worked at Montefiore for a long time, which was an amazing place to work. And I was very fortunate to work in an incredible training program, which the benefit of being an attending in a training program is you have to always be on your toes, which meant I had to always keep learning, which I loved because I was training other people. And that is a really low income, high immigrant area. And almost all of our patients were Medicaid. And what I kept diagnosing patients with eating disorders, not because there was this huge uptick of eating disorders in the Bronx, but I was training my students and me to ask questions people hadn't been asking before. And so the more they asked, we found it, and then we had no services for them.
You know, what's interesting there is that I've always associated eating disorders with more an affluent population, and this is actually surprising. So even in a lower socioeconomic population, this is still a rampant issue.
Absolutely. And I was surprised along the way. I was a founder of the eating disorder program at Montefiore, and we did it purely because I had no place to send these kids. No programs took Medicaid. I worked with our adolescent medicine team there that was amazing. And most of our patients were Latinx. And so when we look at the statistics, usually the highest eating disorders in that group is bulimia nervosa. So that's kind of what I was expecting. What I didn't expect, and we did some research on it early on, was how high our rates of anorexia were. Once we started asking the questions, also system-wide, including in primary care, we were shocked at how many kids we ended up with pretty severe eating disorders. And a lot of it was people were just not asking the questions before. It wasn't that they didn't exist. Nobody was asking. But it surprised me that it was anorexia, not that there were eating disorders, but what type of eating disorder.
Got it. Now, what's interesting about eating disorders for me is sometimes I find that, and maybe this is the case for you as well, where in the general population, it seems like one of those invisible diagnoses where some people hide this very well. And it might be months, years, other behaviors that come about that actually finally bring this into light, either to families or friends or to even medical providers. Are there any sort of particular signs or symptoms with anorexia and even with bulimia that you find seem to be some commonality where if you see these things, you should keep these things on your radar as a healthcare provider, maybe as a coach out there or as a parent?
Yeah, to kind of piggyback onto that, one of the things is the most common eating disorder is binge eating disorder.
Oh, I didn't know that was even a disorder.
Yeah, so there's 5 separate diagnoses within eating disorders, and binge eating disorder is the most common, and it's the one we really don't recognize because there's a lot of negative psychosocial implications, a lot of comorbidity, anxiety, depression, suicidality, self-harm, right? There's a lot of morbidities that go with it, a lot of shame, and the health implications are more long-term. It's not synonymous with obesity, but they often co-occur. So long-term, you're going to have a lot, but the psychiatric challenges along the way are really bad. But then you're right, it's not always noticeable. And so one of the things I think that's hard is I work with a lot of amazing pediatricians, and having seen what training is like working in a hospital and with residents and stuff, training on diagnosing and detecting eating disorders isn't on their radar.
Really?
It's really not part of their training. I mean, at the hospital, we started doing it because we were like, oh my God, because it's something that I think that, especially with an obesity epidemic, right? If any kid goes in and they're told you need to lose weight or whatever it is, and then they drop weight, they're praised for it. It's like rewarded. And rather than asking the questions, so tell me, how'd you do this? Right? Because there may be objective health reasons why it might make sense. But the number of kids I've seen, where was the onset of anorexia? They went in, the pediatrician said, you've gained X amount of weight. You need to lose weight. Your body's not healthy. And then boom, you get this precipitous drop because nobody even asked, well, what went into gaining the weight in the first place? Often, it could have been binge eating disorder. So we see this spectrum back and forth where it feels like you're eating everything or nothing. And so if we don't address whatever that underlying eating disorder is that kind of led, going back a few steps, what led to that weight gain to begin with, and you don't give any real guidance about it, right? Then they're going to feel like it's either I eat everything or I eat nothing. You have this big precipitous drop. And boom, you're now in anorexia world. And it's really hard because also you have those kids that are kind of always below the growth curve. And for a long time, we thought that was okay. What we now know is that's not okay. And so sometimes what we'll see is kids who were always kind of hovering a little below the growth curve. They then have their growth spurt, but they then didn't gain weight. And so their body views it as a loss. And so they develop anorexia and they weren't even trying to because it's just what kicks off in the body and in the brain in particular.
That's so interesting. So it almost sounds like there needs to be a bridge between what you know and what physicians see, because they're giving good advice objectively, saying you got to lose weight because of X, Y, and Z, but it can be actually very harmful if it's not done in a very sort of coached way, I would say, for lack of a better word. Are there what are the kinds of root causes that you have found to be associated with anorexia or bulimia or eating disorders in general?
That's a really great question, because I think what it's also raising is often there's a lot of blame and shame associated with an eating disorder, or even that sense. The number of people have said to me, well, why can't you just make that kid eat? That would be awesome. And it doesn't work that way. It's because eating disorders are what we call a neurobiological illness. It really is all about how different things are in the brain are functioning. And so with that, what we know now, and with anorexia in particular, is there is a huge genetic component that goes with it.
That's striking. I didn't know that there was actually genetics in there.
There's a huge new genome study that it's not so new anymore. And also what's interesting is as they're trying to put together, what else kind of hangs together? We know genetically anorexia and OCD hang together. When you think about it, it makes so much sense because it's like that obsessiveness, but in a different area. And so we know that there can be this very strong genetic predisposition. Now, that doesn't mean anyone who has that predisposition develops an eating disorder. There's always a gene-environment interaction. But more and more what we're seeing is how much that vulnerability based on our individual genetics can make us more prone to an eating disorder. Almost all the time when I'm doing a history, I'll look in and say parent histories. And frequently there will be a parent, not necessarily the mother, right? Both parents, who has some sort of history of difficulties with eating. It could have been a full-blown eating disorder versus more disordered eating. We see that genetic influence. There's also that environmental influence in how it's talked about. But I think there's this great thing put out by the Academy for Eating Disorders called The 9 Truths. Came out a few years ago, which is basically myth busting. And there's also a really good article on the science behind it. Each of those truths has science to back it. And it's really saying nobody can cause an eating disorder.
I see.
And it's not anybody's fault. It's like any other kind of illness. You have to have that, most of the time, that genetic influence that kind of gets you there.
Now, one of the things that you shared with me, Michelle, which was very startling, was the anorexia stats as far as the number of deaths associated with anorexia. I've heard of these things, but I didn't realize it was such an epidemic. Can you go into that a little bit?
Yeah, so I think the hard part is relative to other illnesses, right? It's a smaller percentage. But until the opioid crisis, right, anorexia was the leading fatality of all psychiatric illnesses. It's now number 2, second to opioids. And with that, about roughly half and half of those deaths are cardiac in nature, which makes sense from low-weighted. The other are suicide. And so within all eating disorders, not only anorexia, we do have elevated rates of suicidal thoughts, suicide attempts, completions, and also non-suicidal self-injury. So yeah, there's eating disorders almost never happen in a bubble. There's always comorbidities. But like when people talk about, well, we have to find out what that root cause is, right? it's kind of a misnomer because a lot of it has to do with your genetics and your environment. What's your activity like? What are you taking in food-wise? What are the influences of how things are talked about? It's not like we're going to ever find that one root cause. It is an unanswerable question, and it doesn't help usually.
Now, Michelle, as a healthcare provider, is there anything that I should be thinking about or just suspicious about when I meet some of these teens, maybe young adults, as far as things that might cue me into, hey, this person might have something going on that needs to be addressed?
Yeah, absolutely. And part of why I love being here is I think you are on the front line, right? By the time somebody comes to me, it's already pretty bad, right? They don't come to me because they're noticing some signs. They're coming to me when they're really in distress and their child is really not doing well. And so I think whether it's with athletes, and I know you're going to see a lot of athletes, it's starting to ask questions about, so tell me what your eating is like. Again, a lot of those open-ended questions. Are they eating in a restrictive way where there's food groups that they don't want to be eating? Avoiding fats or carbs are often that. And as we know, you really can't be an athlete without eating those things. As a teenager, are they doing any fasting? So asking about that. With women, I think what doesn't get asked enough is, are you getting your period and is it regular? Because sometimes you can be getting it more often or less often. Both are abnormalities that are an indicator that something's off, right? That a lot. With guys, it's a little harder. The other is looking at how often are they getting injured? Are they getting shin splints a lot? Are they getting stress fractures, things like that? Because one of the things that happens is if you're not eating, your muscles are going to break down, but it also really affects your bone health. And so I think that's where asking those questions in that open, curious way, right? We're not looking for shame or judgment. It's like, so tell me what your eating was like.
That's a really insightful and very easy way to stay ahead of that. For me, being a father of 2 teenage girls, that's always on my mind as far as like just kind of being watchful, like, if there is anything irregular in how my girls are eating, because I don't want to have them go down that dark downward spiral where it can lead to something where they have to have a serious intervention. But that was very helpful. As far as influences outside and triggers, do you think that there's any influence from things like social media that might, maybe if somebody has a genetic predisposition, might trigger that person to maybe go down that downward spiral?
Yeah, I think there's a lot of new interesting studies on the impact of social media. And I think where the danger is, especially, is if you do have somebody who's got more of that vulnerability, they're going to find every trick under the sun online. I've seen it because my patients show me the TikTok videos of what they've got, of all the tricks of not only what do you do to lose weight, but how do you hide it from everybody? And that's where, doing what I do, I can't say I've seen everything, but I've seen a lot, and you'd be surprised at the lengths it happens. And that's kind of what happens with the illness is once it takes over, it's like this entity has taken over your child's brain.
Wow.
And your child's personality isn't the same. And I think that's something to look at too. Most of the time, parents will come to me and say, well, I went to the pediatrician. They told me there was nothing to worry about. I'm a parent, you're a parent. If your parent gut instinct, your spidey senses going off, listen to it, because parents really know their kids well. And if you're sensing they're more withdrawn or they're just not wanting to eat dinner with the family, things like that, they're wearing bigger clothing all of a sudden, they're wearing sweatshirts in the middle of summer, those are the kinds of things where this is an illness, anorexia in particular, that it wants to do anything to survive. Somebody with anorexia, they will engage in behaviors to really hide it from the outside world. And they're really successful for a long time often.
Man, that's eye-opening for me. And thank you so much for sharing that. As far as things that have worked, we talked about how fad diets often don't work. What are some things that you have found in your role as a psychologist that have been more effective or most effective in working with young adults or teens with eating disorders?
Yeah, so I want to make sure we have hope here. Here's the really good news is eating disorders, and if we're going to say to anorexia in particular, is 100% treatable.
Wow.
Right. That's one of the myths is if you have it, you've got it for life. And so that's the good news is once we are able to detect it and diagnose it, and the earlier we detect it, the better, we can really have 100% cure rate.
Wow.
Now, unfortunately, the treatment isn't fun because the treatment, food is medicine. There is nothing that will cure anorexia other than restoring weight. And so, what the evidence shows us is the best first-line treatment in children and adolescents is we call family-based treatment. And now we also have a version that's parent-focused where you're only working with the parents and it's similar. We look for a rate of gain of 1 to 2 pounds per week is what we're looking for when they're outpatient. But it's all about getting the food in and being really behavioral. The hard part is when if you've ever known somebody with anorexia, they can come across as the most logical, rational person in terms of how they're going to talk to you about why they should or shouldn't have a particular food. And the hardest part is that you have to make them eat to the point of feeling really full. So think about having Thanksgiving dinner 5-6 times a day.
Oh my gosh.
And that's what it feels like because, right, in order to gain weight, you're eating more.
Yeah.
And the other hard part is when somebody develops anorexia, they go into what's called a hypermetabolic state. And so it's as if they're running and burning it up every time. So the number of calories we need per day to get even 1 pound is way more. So like even just visually looking at the amount of food that's needed is often challenging. And food is medicine. That becomes the mantra.
That's great. So it sounds like a big lifestyle change and habit change needs to be incorporated. And I love how you said that this is not a road that you can go alone. You really need to have that support of your family behind you to be successful, especially as a youth or as a young adult.
Yeah, and I think it's hard. And I'm most of the time when I first meet patients, I'm the devil incarnate. I have been called every name under the sun because I am the one who is telling somebody's parents, you need to feed your child. And so the idea with FBT is we arm parents and put them in charge of refeeding their child, like some guidance. Sometimes we work with dietitians. It depends on the family with the idea of, what a kid needs to eat. We need to go back to feeding your child, not what they're asking for, but what their body needs to fuel their body. And as with somebody with anorexia, they literally will kick, scream, fight every step of the way. And so it means not arguing and really, my job is a lot of the time working with the parents to set those behavioral limits and try to stay calm themselves. The other big piece of it, though, is, as I said, I can't do it in a bubble. The medical specialty that most people don't know about, I never knew about until I did this, is called adolescent medicine. So they are pediatricians who've done a 3-year fellowship in adolescent medicine. That's different than a pediatrician who teaches adolescents. It's a subspecialty. And they are trained in the medical aspects of eating disorders. Oh. And so I work hand in hand with them because with all of this along the way and, taking weight and things like that, we need to be looking at vitals, blood work, right? There's a lot of things that go wrong when your body's malnourished, right? Heart rate, blood pressure. And so along the way with this, we're balancing refeeding and making sure that they are stable enough to be in an outpatient setting.
Michelle, are there like 1 or 2 strategies that have been very successful for you to tell parents as far as getting their kids to want to eat when there's so much resistance from this population?
Yeah, the part of it's actually written into the treatment early on is raising parents' anxiety about the dangers of the illness.
I see.
Well, if you have a family, though, that's overly anxious, right? We want to calm them and give them hope, right?
Yeah.
And so part of it is helping them be focused on this is your child's medicine. And I'll use often the analogy, God forbid your child had cancer and you had to put them through chemo. If you've ever watched somebody go through it, it is awful. And there's nothing worse than watching your child suffer. It's terrible. And so you wouldn't blink an eye at doing it, because it's saving their life. And so that's the same thing, is giving them this idea that this is life-saving treatment. Your child can die from this illness and we need to do this. And so the other piece is I one of the types of therapies I'm trained in is something called dialectical behavior therapy, which has a lot of skills associated with it. And so often what I will do is also have once a week separately where all I do with the parents is work on these skills to really give them the tools for distress tolerance, communication, behavioral principles, because I want to arm them with how to do this. I'm guiding them along the way. The good news is once they get the hang of it, they're really able to do it effectively. And so I'm coaching them through it.
That's amazing. Actually, we've talked about this before, how communication is so important. I can imagine even just dealing with a teenager in and of itself is a challenge, let alone compounding that and layering it with an eating disorder. I can only imagine how much you have to sort of hold your tongue as a parent and communicate effectively so that you don't cause this sort of like resentment between you and your child who's going through this, horrible issue.
Well, I think actually that's one of the hardest things is parents are so worried that their child is going to hate them forever. And I wish I had that ability for parents when they're early on to really see what I see of this other end of how amazing it is when we get there and they literally get their child back and, and their child loves them again, to let them know setting those limits and doing what you have to do. Short term, they are going to hate you. Just like I told you, they hate me for sure. And as a parent, we often have to do what our child needs, not what they want. And so the more I can keep them focused on that and let go of what their child is saying to them and remind them, this isn't your child. This is the illness talking. Because personality-wise, your child's not the same. And we're doing this because this is what your child needs. Now, the treatment is really hard. And you know what? And not every family can handle it. And there are times where we do want a higher level of care. Either the illness is more severe or for a lot of logistical reasons, we need to do it. But again, the good news is if you're getting the right treatment and we treat it early and aggressively, we really can have 100% recovery. And that's so important. But that's where you and I have paired up, kind of evolved organically, with John, is the earlier we can detect it. So you guys being able to see it among athletes and the earlier we can intervene, the better the prognosis.
For sure. Yeah. It's been a very interesting experience working with you in this regard. And two things I want to touch on real quick. Number one is that there's a common myth, I believe, that this is predominantly in females. And in your experience, that's not often the case.
So I think statistically, it is still more female than male. And so some of the question out there is how much of that is it's underdiagnosed in males versus there's a true discrepancy. Right. Not as sure. Yeah, it presents differently in males. And I think that's the thing is when you're working with males, it's often asking different questions. It's not absolute, but for most females, it's much more what you think about, the number on the scale, but we'll still have that body dysmorphia of not liking certain parts of the body, wanting to lose weight and wanting to often hit a certain number. With males, often, even if the number is important, they won't talk about that. It's much more this muscle dysmorphia, right? And so it comes out of I want to build muscle. I want to have a six pack. And sometimes, John and I shared a patient where he wanted a six pack and his thought was, if I'm losing weight, it'll pop out more.
Oh my gosh.
Right?
Yeah,
and not realizing he was actually breaking down muscles and not building muscles, and had a very ritualized exercise routine. It was like 1,000 push-ups, 1,000 sit-ups, stairs every single day early in the morning.
Wow.
And then when John assessed, he wasn't doing it with proper form. So he wasn't getting the effect from anything. So that's where often it's like they want to change the shape of their body. That being said, as much as they won't necessarily talk about the number, if I put them on the scale, they don't like the number, right? So it is there. It's just that it's much more about wanting to build muscle or more for performance. And so with females, you are going to see it with performance as well, especially in athletes. But it's the same illness, but it's going to present differently. The interesting thing is with guys, it actually can be more dangerous because when they start, as most women will complain, right? Guys will lose weight faster. When they start to lose, they lose faster. Oh. And so rate of weight loss is what causes a lot of the cardiac dangerous because the faster you lose, right, that can cause bradycardia or a slower heart rate. And so that's where, it can be pretty dangerous and we want to watch it.
Yeah, now I think back to my high school days and I worry about wrestlers, especially because sometimes, I remember I wrestled for a short stint, but the amount of weight you'd have to lose to make certain weight classes was not only dangerous, but very unhealthy. And, my worry as I think about this more now is, wow, how many of those guys are being underdiagnosed with the possible eating disorder?
Yeah, when you look at athletes across the board, but even like looking at high school athletes, I heard a statistic literally last week that from a reputable place that about 42% of high school athletes across the board has some form of disordered eating or a full-blown eating disorder. So it might be like they have rituals around eating or rules around eating, not necessarily an eating disorder, but they're doing things to change their body based on whatever beliefs about eating. But what we also see is that there is a higher risk factor for developing an eating disorder, especially restrictive eating disorder, among athletes in sports that are weight or body based, right? So wrestling, dancing, gymnastics, runners, or where there's this belief that I need to be at race weight, which we know race weight is different for different people, and being smaller doesn't always make you faster, right? Correct. And we've seen that among pros and others, that it's finding that weight that's going to be right for you, not an arbitrary number. And so the ones where there is this tie between weight and performance, they are higher risk. Now, the protective factors are coaches, PTs, who are giving the messages not about, right? There was a long time, and there's a lot written of being weighed by coaches and, and making sure you have to lose weight or whatever it is, which definitely led to lots and lots of eating disorders. Sure. But the more coaches are educated on how to talk about it and be supportive and have it about how do we have a healthy body holistically, what does our body need, giving those positive messages about what we need to fuel our bodies as athletes, as opposed to what we're seeing in social media diet culture, that's actually going to be a really strong protective factor. Because as we know, coaches have huge influences on kids. Yes. And it can be really positive or really negative. And so that's where a great coach can do so much to either detect or prevent something like that.
I'm so glad you mentioned that. And I think I need to connect you with some of our other coaches, because the people that we do partner with in the community who are like-minded with us, they do have a very sort of like holistic view of their own team. And they do want the best for their athletes for the long run, not just for the season, not just for the year. But some of our coaches will say, hey, listen, I just want to make sure that our kids, whether it's soccer, volleyball, or what have you, are on a path towards making great choices for the future, and not just for the immediate moment of making college sports or what have you. It's like, I want to set them on a path where they have great habits and lifestyles that will sustain them as they get into 30s and 40s. And I was like, that's really powerful. And this really ties in nicely with being able to do that and have an influence now while these coaches are working with these different teams in their youth. So I'm excited to actually see how we can integrate that in future things that we do together. One of the things I wanted to ask you was, as you know, that we also have a very whole person approach to how we do rehabilitation and physical therapy and fitness with regards to the medical population and athletes and active people. And our team has been working with you closely, especially over the last 2 years. And it's very, very exciting to see us going into this realm, because it does hit near and dear to us as far as being able to provide a whole person outlook to all populations that we see. But I think common out there, the notion that, I didn't know that physical therapists can work with clients with eating disorders is kind of a myth in itself. Can you talk about your experience, Michelle, as far as having our team work with your clients, how that's been, and what it is that you thought would be beneficial about say, physical therapist working with their clients than some other kinds of professionals out there?
Sure. So it actually kind of came out pretty organically based on my own history of having been in an accident. I'm here a lot and work with you guys to keep my body all in one piece. And over that time would talk about what I do, right? I was working with John for a long time. And over time, he would just ask questions about, eating disorders. And actually, he detected a couple of kids early that he's like, because he couldn't unsee it then. And there were kids that he would then say, I have this patient, what do you think? And then would connect them to me. And sure enough, they had anorexia more than once. And so as we went through it, as somebody who is active, a triathlete, and, the benefits psychologically of movement, right? It never made sense to me that this whole part of the eating disorders treatment world is no movement, no exercise, let's just stop it, which I get, right? Because if you're moving, you're burning calories, and that's going against what we're trying to do of refeeding. But it doesn't make sense, right? From the sense of if, you are like have anorexia, you likely have bone loss. What's one of the best things we can do to strengthen bones?
Absolutely.
Right? Is strength
Movement.
training,
Yeah,
right? And movement. And the other is, right, when you're part of what happens with anorexia is when you are malnourished, your neurotransmitters are also changing, which means you're more anxious and more depressed because that's what happens when your neurotransmitters. So we're also dealing with those comorbidities of mood and depression and people feeling like I've lost everything. And so finding ways to integrate it in a very healthy way that doesn't get in the way of weight restoration, both in terms of the physical is helpful, but also the emotional, right? Because if you're sitting there doing nothing and you're getting all that muscle atrophy, the other thing that happens is, especially if they're an athlete and then they go back to sport, what's the likelihood they're going to get injured?
Absolutely.
I mean, that's your expertise. If they've
Right.
all of a sudden have all of this loss of muscle, right? They're going to go out there, they're going to get injured, as opposed to how do we do it? The other huge benefit is in our field, I think one of the things we are not great at as a field, unfortunately, we're better than we used to be, but we're still not great at really getting rid of the illness, is those that come in with that obsessive compulsive exercise, kind of like the kid I was talking about, where they have these very strong rituals, or they have to exercise even on injury, right? They can't take a rest day. They're doing, or if they're on a team, they're doing above and beyond what the coach has said to do, right? Always doing extra with a drive to do it either to make their body stronger or most of the time to lose weight, which we know we need rest and recovery. Otherwise, we're going to break things down.
Yeah.
And so that's where working with John on that, we were able to re-educate on, okay, so your goal is a 6-pack. Okay, well, we can't do that if you don't have muscles. You're not going to have muscles if you're not eating. And so what it's also doing is like retraining on not just healthy, balanced eating, but healthy, balanced exercise. And I think in doing that, we've got a win-win. There was a study done recently, because there's not a lot of work in the field on doing this, because there's a whole part of the field that is very anti-exercise in treatment. It's got a growing popularity, but showing there was no negative impact on weight restoration when it was done the right way. And so part of it is, and philosophically, part of how, I train and people train is heart rate. And so one of the things we do early on is we have them wear a heart rate monitor.
Nice.
So that we're keeping their heart rate low so they can be building muscle, but not increasing their heart rate to the point where they'd really be burning a lot. It also is then a feedback loop, because often one of the things, right, is their perception of perceived exertion is skewed. And so we're also able to kind of have them realize, oh, I think I'm working out this much, but my body's telling me something different. And that's a really important thing for an athlete to be able to really learn and know your body. So I think it's been really successful. The other is often I can get messages snuck in that way that they don't want to hear from me. And, again, it's a multidisciplinary thing. All of my patients I have right now that are with John, I'll call him and say, okay, can you make sure that they understand why fats aren't bad? Like, things like that, which he's able to then give those messages in terms of directly why they need to eat those nutrients in order to hit their goals of muscle or fitness or whatever it is.
I love this multidisciplinary approach, and we are really big on education and different areas too. And a lot of times we will tell clients who are starting with us that listen, you're coming in with this injury, but there's a whole host of other external factors that are going to play into how well you recover and how fast. And nutrition is one of the biggest ones that we harp on. And so it's great that you're emphasizing this and how we get to partner with you to help these clients understand that nutrition is really important for you to get to the goals that you want to, but also so that you can actually live and thrive as a healthy individual. So it's great. Michelle, it was a pleasure having you on our show. Thank you so much. Is there a way for our listeners to reach out to you?
Sure. I hate to admit it, but I don't have a website.
Oh my God.
I've been fortunate, a lot of word of mouth, but people can shoot me an email. I'm sure you can put it in the notes. It's Michelle@drmichellepupkin.com, no punctuation. And you can always shoot me an email, and always happy to consult. Usually that's the first step, is I'll have a call with somebody and just get a sense of, am I the right fit? What do they need? Connecting them with an adolescent medicine person, and then we go from there.
That's great. And that information will be in the show notes. Thank you again, Michelle. And for all of our listeners, have a great day. Until next time. Thanks so much for tuning into today's episode. It really does mean a lot to us. And don't forget to like, share, subscribe, or comment if you got at least one or two helpful insights or takeaways to help you get to your next level.